Thank you. Good morning, good afternoon, good evening, everyone. I hope I can be heard. I'm going to share my screen as well. I bring you greetings from Uganda. And in West Nile region of Uganda, we are implementing a project titled TB or Not TB, creating a safe living context and holistically improved healthcare for TB patients and their families from refugee and host communities in Northwest Uganda. I am representing Uganda Catholic Medical Bureau, which coordinates all the Catholic facilities in Uganda. So as I mentioned, this project is being implemented in West Nile, that is bordering Democratic Republic of Congo to the west and South Sudan to the north. And we can see that we're targeting refugees and host communities. We know refugees move for different reasons. We are already seeing this a lot on the news, like what's happening with Ukraine. And similarly, from South Sudan and DRC, we've had a big influx of refugees in Uganda for security reasons, economic reasons. And these refugees, as you may be aware, are settling in different settlements. However, this project is targeting 3 districts which have settlements. That's Koboko, Terego, and Madiokolo. And the refugee settlements there are Lobule with 5,300, Mvepi with 64,000 refugees, and Rhino Camp, the biggest for our project, with 116,000 refugees. The objectives of this project, the TB or Not TB project, are to improve TB care, psychosocial and economic conditions of affected people and their families using community-based holistic approaches. And then strengthening capacity and empowering refugees and the host communities to meet economic, social, and health needs, but using tuberculosis as an entry point. So I'll just pause a bit and throw more light on this objective, that this project is unique because more than just case finding, the project seeks to improve economic and social well-being of the refugees who have come in and their host communities where they have been received. And then we also have the third objective of contributing to better networking and knowledge exchange and learning, like we are doing in this webinar. So this is a schematic just summarizing what I have just mentioned, that we're looking at health using TB as an entry point, but we're integrating social aspects, social determinants like sexual and gender-based violence, and also seeking to improve the economic status of TB-affected households through agribusiness. We know in Uganda that 54% of our TB-affected households face catastrophic expenditure as a result of TB. We work with other sectors, including Ministry of Gender, with the Office of the Prime Minister, which is responsible for handling refugees. We work with other partners in the region who are handling other services, including HIV, like the Infectious Diseases Institute. And we also work with other partners supporting refugees. And all these are done with the endpoints of, yes, detecting additional TB patients and successfully treating them, but also improving the social and economic well-being of TB-affected households. Yeah, these are the interventions in terms of activities. This diagram just summarizes what we do. We work with health facilities. Currently, we're working through 24 health facilities across the 3 districts where we conduct facility level TB screening, but we also have community level TB screening. We use the intensified case finding guides, but we've now added digital X-ray, which was non-existent in the region, to the screening modalities. On top of that, we also screen persons with diabetes. We also target high-risk groups, especially people living with HIV, people with malnutrition, who we also support with food supplementation. And we also use GPS locators to track patient treatment and map their TB households, map the TB households in the community for follow-up, and all this aimed at achieving treatment success with integration of screening for gender-based violence at that level. So these are the districts, Madiokolo, Terego, and Koboko, and the 3 refugee settlements that we are targeting. Now that brings me to the topic for today's webinar, which is the digital X-ray, which I'll focus on going forward. We received 2 portable digital X-ray machines, which was supported by the donor for this project, who is the German government. And these were procured from Delft. They are both Delft Light, and they are stationed in the Regional Referral Hospital in Arua, and another one in Maracha Hospital. So these machines are positioned in a kind of hub and spoke, but the beauty is that since they're the only ones in the region, they are not only restricted to these 3 districts, but other partners are able to borrow machines and conduct outreaches in their districts, as long as they return them safely and with all components. This is just a photograph showing the handover of these digital X-ray machines, which we received with support from the German government to the government of Uganda. We can see the German ambassador and our Ministry of Health officials, as well as officials from Uganda Catholic Medical Bureau. So when we received the machines, we handed them over to the 2 hospitals which are serving as hubs. On our left, we have Arua Regional Referral Hospital. And then on the right, we have Maracha Hospital. These are hubs. The beauty with this machine is that it's portable, solar powered, so it's able to be used deep in the communities where there is no electricity, and it's able to reach the hard to reach communities. And in West Nile is very big. Just to put it in context, it is bigger than Rwanda and Burundi combined in terms of geographic coverage. The roads are not all good, so this machine will help us and is helping us to go very deep in the community. We conducted trainings to build capacity of the health workers in using this new technology, mobile digital X-ray, solar powered, but also equipped with card for TB, which simplifies life, because in our setting, we are not very well staffed with radiologists. So this card for TB enables us to fill that gap. So this is just a photo of one of the outreaches. As you can see, this is one of the clients, and our team is set up there, and there are some images, some heat maps demonstrating what we see as a result of these screening outreaches. In terms of numbers, this is a summary of what we've managed to achieve. For instance, if you look at the first column, those are the health centers. This is a snapshot, and within 8 days, we have been able to screen 862 individuals. In such a short time, we're able to screen so many because of strong community mobilization, as well as working very closely with the district TB and leprosy supervisors to mobilize those who are eligible for screening. Out of those screened, we had about 49 with abnormal images. We're using a cutoff of 60% card for TB. And we went ahead to further screen these 49 patients using GeneXpert, and we found 9 were, beg your pardon. Yes, 9 had MTB detected, and 40 were MTB not detected. And then we had all the 9 bacteriologically confirmed were started on treatment, and we had 11 who are clinically diagnosed, because we know that even if we have a negative GeneXpert, we can still make a clinical diagnosis and treat TB. This is just a snapshot of what happened in Arua prison, Arua main prison. Arua is not one of the main districts where the project is being implemented, but it's the hub where the machine, Arua Regional Referral Hospital is the hub. And we did this because it's a government hospital, so it also enables us to increase utilization of this machine within the government setting, within the government-owned facilities. UCMB-owned facilities are private not-for-profit, so we placed the machine, one in the government facility and the other one in a private not-for-profit facility. So this is the outcome from a camp conducted in the prison in November last year, where 751 prisoners, inmates were screened. And out of this activity, we managed to detect 2 bacteriologically confirmed cases of TB patients, and then 2 had clinically diagnosed TB. So we were able to treat 4 individuals with TB. As I move towards the conclusion of my presentation, how do we conduct these outreaches and how do we organize the outreaches? We make arrangements with the respective district TB and leprosy supervisors who mobilize teams to go out and book eligible clients from the community and send them to identified outreach points. Usually the outreach points are either a health facility or a specific spot in the community where people can convene. And on arrival at the outreach point, we are very sensitive of infection control procedures, including COVID-19 SOPs. We provide health talks initially to the clients about TB. We also integrate COVID-19 messaging. We provide them with we make sure everyone is masked and all the necessary sanitizers are available. And the purpose and eligibility of the outreach is also re-emphasized in this health talk. And then we use the Ministry of Health X-ray screening forms to screen the clients who've been mobilized, and presumptive patients with presumptive TB are registered in the presumptive TB register and then screened using the digital X-ray. Those that have the score above the threshold of 60% further proceed for further testing using GeneXpert MTB rifampicin test. So that's a picture showing some of our mobilizers. We equipped them with bicycles, we have motorcycles, and all this is to enable reach into the hard to reach communities where transport is a challenge, roads are bad, a number of communities are sparsely populated. You have to travel long distances to reach households which are scattered. And that's why we have this strong force of community mobilizers. What challenges have we faced in this? We experienced a minor downtime of the machine due to minor technological glitch. But this was resolved by the local Delft representative, RIMA East Africa, in partnership, working hand in hand with a team in Ghana. We also experienced security challenges of the equipment while in the field, especially in Arua, where components of the machine, it has a tablet and dongles, very small parts, which we have learned from experience have to be very keenly followed and secured. So we introduced SOPs, standard procedures for handing over and release of each component from the store with a standard checklist at the point of handover as one of the stopgap measures to beef up security, or of course, including engraving the equipment. This is one of my colleagues just carrying the Delft Light Pack. And in conclusion, what have we learned? That portable digital X-ray with computer-aided diagnosis for TB, coupled with other diagnostic modalities, is critical in strengthening TB case identification towards the last mile of ending TB by 2030. Thank you very much.